My name is Dr. Michael Lee. I'm the founder of Crossroads Brain Spine. I am the clinic director at Disc Center Indy. Some of my credentials: I was voted a top 5 decompression doctor in the U.S. I have a national certification in spinal decompression, one of 2 doctors in Indiana to hold that. And I authored a textbook while I was in St. Louis on infrared thermography. I'm not going to get into that today, the infrared thermography, but that's a textbook that I wrote. I want to introduce the relief healing framework that I developed. We're only going to talk about non-surgical spinal decompression today, which is just one of the things that I do, but this is an acronym. So R is realign the upper cervical spine to restore proper nervous system function. E, ease disc pressure with non-surgical spinal decompression, allowing rehydration of the disc. As Dr. Swiatek talked about, when there's compression of the disc, loss of disc height, that causes a myriad of problems. Non-surgical spinal decompression is a great intervention to restore the disc height. I have a class 4 laser therapy. I have 2 class 4 lasers in my office, and those reduce inflammation, accelerate healing, and ease pain. I have a few slides if we want to really dive deep down the physiological rabbit hole of how that works. Obviously, we know that nutritional supplementation and having a chemical-free, anti-inflammatory diet is really, really important, particularly when we're talking about disc health and reducing inflammation. Not every patient I will equip with a back brace for support, but some cases this is really crucial. And then follow up with functional rehab. I don't do any rehabilitation in my office per se. I will give some patients some exercises that I think is good, but I am not a physical therapist. And this is where having a referral network with other physical therapists is really good, because these are all patients that I send out of my office. People ask, what are the best exercises I can do? Super easy referral. I don't know, go talk to a physical therapist. So my 3 takeaways for us tonight is not all back pain needs surgeries or injections. We're going to talk about real results you can see. I have an on-site radiology facility in my office. So I take pre and post radiographs on all my patients, and we speak the same language and we work as a team. I was talking with somebody earlier today about how my intervention is very niche, it's very specific. Anything outside of that, I refer out. So that's why I want to continue to build my network, because I'm really good at what I do, but I'm not good at what everybody else does. So if I can send patients out to somebody that only does exercises or massage or acupuncture or dry needling, that's not something that I do, because the jack of all trades is the master of none, right? So let me tell you about Tony. Tony was an interesting case. I have permission from all these patients to share. You can see he's hiding his cane here, but so Tony's daughter, I actually went to high school with her, and she says, hey, do you know anything about drop foot? And this, as Dr. Swiatek said, this used to be a video, but now it's a picture. So this is a patient that I had with drop foot. I did 1 non-surgical spinal decompression treatment with him, and in the video he talks about how his drop foot improved. So I sent that to her, and she said, well, my dad doesn't have any pain, but he has drop foot, doesn't walk well, 2 new hips, which is very common. He's not doing great, just trying to find him solutions, I guess. He's up in Elkhart, which is 3 hours, where I grew up, so I graduated with her. 3 hours away, but maybe if he's down here, he'll come and see you. Well, he came to see me June 24th, drove 3 hours one way to come and do a consultation with me. He presented to my clinic with pain, this discomfort that started a year and a half ago. He started to notice that his foot was dragging, and it got progressively worse in the last 30 days. Again, he had really no pain at all, but he said this is a severe issue and it's constant. He had been to the neurosurgeon, he had been to the neurologist, he had been to the physical therapist, and none of them were able to help his drop foot. He had an MRI and an X-ray before presenting to my clinic, and his main worry was he was worried about becoming handicapped with a walker and a cane, and he presented with a rollator walker in my office. And he wanted to get back to normal activities like gardening and boating. Tony really loves being on his boat, and he said, I can't walk down to my boat. So I did a physical examination with him. He had decreased myotomes, dorsiflexion, which is the L4, plantar plantar flexion, which is S1, of course, and he was hyperreflexive at L4, L5, S1. So I want to do a really thorough physical examination with all my patients to really get an understanding neurologically of what's going on with him. So, like I said, I take x-rays in my office with every single patient because, as Dr. Swiatek said, it's really important to have the imaging, but it's really important to have a follow-up physical examination that correlates with that. So here we're looking at a sagittal view of the lumbar spine. He had preserved disc height at L1, L2, preserved disc height at 2, 3, 3, 4. We started to have some of that compression, L4 or 5, which you would think as a clinician like, okay, L4, L5, he's got decreased myotomes at 4, 5, he's got drop foot. That's probably the level that we would treat. Well, 4, 5 didn't really look all that bad. Some moderate compression, but then at 5 and 1, you can see that 5 and 1 are just slammed on top of each other. We go from 39. So what I do is I measure the anterior third of the disc height and the posterior third of the disc height, and then I get a correlative measurement of what the disc is below. And we know that L5, S1 is always a little bit smaller, but not from 39 to 12 and not from 39 to 19. So we had severe discompression in L5, S1. So I recommended to Tony, we're going to do a minimally effective dose of treatment, which based off of his symptoms and based off of my experience, I said, hey, let's start with 25 treatments and let's see how your body does. We're underestimating here, but let's just see how your body does, because I always want to take into account the cost burden on the patient. So I recommended a minimally effective dose of non-surgical spinal decompression and class 4 laser therapy, all within my relief healing framework. My objective of my treatment with Tony was to restore the disc height at L5, S1, reduce the severity of the drop foot, and correlating with the ADLs, I wanted to improve his mobility and his independence. So we did 25 treatments with Tony, and as clinicians, we kind of have this gut feeling of they're not quite there yet. If I could do a few more treatments with him, I wonder how much better he would get. And with this type of therapy, we can do that. So he wasn't quite there yet. And I said, Tony, if you were my dad, I would do some extra treatments with you. And one of the core values of our business is having a servant heart. So I'm going to do extra treatments with you until you and I both feel like we're ready to reevaluate. And I'm not going to charge you for those extra treatments. Is that okay? And Tony started to well up and he said, nobody has ever treated me like that. So I saw Tony for 32 treatments. And at that point, he just said, hey, I think it's ready to see what has changed. So when we look at his post 32 treatment x-ray, again, I have it in my office, and I don't charge patients for the follow-up x-ray because that's an imaging modality that I want to see. So again, cost burden of the patient, I want to try to keep it as affordable as we can. At L3, L4, that's where we start to see mild compression of the disc. He had a 17% increase of the anterior disc height. Posterior disc height is covered up here, but he had a 33% increase of disc height at 4-5, and he had a 50% increase at 5 and 1. This was taken October 16th of 2024. We did his review of progress. So once I reevaluate a patient, I say, hey, let's take a little bit of time off and see how well your body does without getting treatment, because I don't want to have them keep coming in day after day, week after week. We want to see how well that treatment is without getting continuous therapy. So he said, I'm 90% better since starting treatment. He reported he was not dragging his foot as much. And what's beautiful is that, this is a direct quote, he said, there are times at home I forget to use my cane because I don't depend on it as much. I'm definitely more mobile and feel like I have more independence. He came to me in a walker, and now he's forgetting to use his cane. That's a great, great thing that we've been able to do for Tony. And if I would have only used my physical examination, I would have been treating the wrong angle, which is really cool. With the DRX 9000, we'll talk about this more, but it's been cleared by the FDA since 2002, meaning it's safe and effective. And traction and decompression is not the same thing. They're two different modalities, but from a marketing perspective, a lot of patients, a lot of doctors say they have a traction table and they say they're doing decompression. But one of the beautiful things about the DRX-9000 is that we can change the angle of the pull to target the specific disc. So with Tony, we had a 10-degree pull to target the L5-S1 disc. If we were going to treat the L4-5, it'd be a 15-degree pull. But having the FDA clearance is important because we know that it's safe and effective. So when I treat patients, I can sit knee to knee and eye to eye and let them know that, hey, there's research backing this up. This is not just Michael coming up with this. This is the FDA, which is cool. So I want to talk through some research studies. The McClure study, Dennis McClure was an orthopedic spine surgeon. This is a hallmark spinal decompression study. He had 500 pre-surgical candidates, all with MRIs confirming a disc pathology, and he used the barometer for success of a 50% reduction of symptoms. And of these 500 pre-surgical candidates, 88 to 92% of them all had a 50% subjective report of improvement, which is wonderful. The Connolly study, this was a study that was just published about a month ago. This was a case study that studied 13 patients aged 18 to 82 with an intervertebral disc lesion diagnosed with a MRI. Patients underwent 20 DRX-9000 treatments. They had a subjective improvement of pain of 80%. They had an improvement of disability by 50%, and they had a subjective recovery of 75%. Pretty incredible results, patients doing DRX treatment. What's cool is that they got, with the Connolly study, they got post-MRIs that showed that the disc height actually improved 1.0 to 1.6 millimeters, and the central canal A to P dimension increased by 1.5 to 2.1 millimeters. I've been studying this for 2.5 years, and anytime I would go to continuing education, nobody would get post films in patients. Patients were subjectively better, but as a scientist, I want to know objectively what does it look like, and the Connolly study proves with an MRI that we can increase the disc height, which is really cool. The Leslie study was a study that came out of the Mayo Clinic. This was a prospective, multi-center, phase 2, non-randomized control clinical study with 20 patients that reported 6 months or more of symptoms. Again, they did 20 DRX-9000 treatments lasting about 6 weeks. 88.9% of patients reported improvement in their back pain and better function with their ADLs. And on a 10-point scale, 1 being I would not recommend, 10 being I would absolutely recommend, patients rated 8.1 on the satisfaction of the treatment process. On the objective side, which is really important, Oswestry disability scores went from a 23.7 to a 5.5. That's statistically significant of their disability scores, and pain medication decreased. The importance of this is that no patient comes into my office, and I'm sure no patient comes to our office and says, I want to take more opioids. I want to take more pain medications. In fact, we've kind of been on this anti-opioid stretch for 30-something years because we know the long-term effects of how opioids affects people. This was a study coming from Johns Hopkins. This was a case report. 69-year-old with an onset of low back pain for 2 years, progressively worsening pain with radiating pain in the buttocks and legs, so he had a radiculopathy. His MRI showed disc protrusions L1 through L5. This guy's got 5 disc protrusions. No wonder why he has this radicular pain. 22 DRX-9000 treatments. Pre-treatment, the patient reported a 10 out of 10 pain. Patient reported 1 out of 10 prior to treatment, 90% improvement. He's beating the odds by 40%. And post-treatment, he denied any radicular symptoms. Post-care MRI showed decreased herniation size and increased disc height, which is absolutely awesome. Sharon is a patient that's really special in my heart. Number one, we share the same birthday, so I may be a little biased. But she was a CNA for 33 years. All those years, bending, lifting, pushing, pulling, wore down the disc of my neck, started having problems with pain and stiffness about 3 years ago. I wanted to keep working, but had to do something about the pain. She had an ACDF surgery, unfortunately, with Sharon that didn't work out. If she would have went to Dr. Swiatek, it probably would have worked out. 3 of her cervical discs were fused together over the past 2 years. That has been over the past 2 years. She thought surgery was her only answer, it only made it worse. She never went back to work. She has lost a majority of mobility in her neck, and the stiffness and her pain in her neck is constant. She had 3 injections, and those didn't help either. Those were post anterior cervical dissection fusion in her neck. This was Sharon, as you can see by the smile on her face and by the smile of my face. Treatment works for her. So even with patients that have fusions, we can still treat them because we can change the target level with the DRX 9000. You cannot do that with traditional traction. Stiffness, pain improved, spinal decompression relief is just what I needed. She gets the laser therapy in our relief healing framework. Dr. Lee and his staff are kind of compassionate. They truly care about helping people. My only regret was I didn't visit them before surgery. There's some patients, there's an 88 to 92% success rate of non-surgical spinal decompression. There's 10% of people that I can't help. That's when we send them to Dr. Swiatek. But there's a 90% chance that it could. And this is a patient that she said, my only regret was I didn't try them before surgery. If they try them and it doesn't work, it's not going to make them worse. That's a great referral for a spine surgeon like Dr. Swiatek. But with non-surgical spinal decompression, this is an intervention that we can try before a surgery. Because as Dr. Swiatek says on his video on his website, I want to help as many people as I can before they have a surgery. This is a great intervention to do before they have a surgery. Norris is a great patient of mine. If you want the expanded version, we can talk about it after the presentation. I thought I was going to get scammed by the Bahamian government. Norris was from the Bahamas. He came here, he was visiting his daughter, he fell, he hurt his back. His daughter calls my office, he schedules a consultation, his daughter calls my office and says, I don't know how to get there. And my staff says, well, we're at 9240 North Meridian at the corner of 93rd and Meridian. And she says, no, we're in the parking lot. I don't know how to get him up. And my staff's like, well, what do you mean? Like, he can't walk. And so we bring him a wheelchair and literally his daughter wheels him into my office. And this is him about 90 days after his treatment. He was able to leave our office walking and was able to fly back to the Bahamas. He was stranded here because he couldn't be on an airplane because he couldn't walk. So Norris is a wonderful, wonderful patient. But not everybody's like Norris. Not every patient is like Tony. Let me tell you about Tom. This is a sagittal T2 weighted image. Correct, Dr. Swiatek? This is a T2 weighted image? I'm not completely dumb? Right. This is a T2 weighted image. As we can tell, there's... Dr. Swiatek, would you call that an extrusion at 4.5?
I'd have to... I said the stenosis, and I thought with it.
But there's definitely a problem at 4.5. So Tom presented to my clinic with tingling in his feet and his toes, no known reason, bilateral pain across his back. He said he's got that stabbing feeling bilateral in his posterior thighs. He said the pain was severe and constant. He had been to the neurosurgeon, he had been to the neurologist, he'd been to physical therapy, he had been to chiropractors. Nobody was able to help him. Obviously, he had the MRI, he had cortisone injections, and nothing was working. And funny enough, during his consultation, he said, yeah, I had a fusion in my neck, and I'm still having neck pain. Why is that? And I said, you should have went to Dr. Swiatek. So this on the left is a pre-treatment x-ray we took right before Christmas 2023. We have a mild compression at 2 and 3, starting to get compression at 3 and 4 and 4 and 5. Here, about 4 months later, we have post films to show that we were able to increase the disc height. Pretty nominal, right? Increase of disc height. But I showed Tom, hey, we were able to increase the disc height, which is one of our treatment objectives that we do, because if we can increase the disc height, we improve the hydration status of the disc. So Tom is a very similar patient to Tony. He initially started with 25 treatments, and we were targeting the L4, L5 disc, which is a 15-degree angle on the DRX. And we got to 25 treatments, and he said, as we were going through treatment, he said, it's getting a little bit better, but not really that much. And so I said, okay, Tom, well, let's change the angle. Let's go from 15 degrees, L4, L5, to 20 degrees at L3, L4, and let's see if we can get things to change. So we did 5 additional treatments, again, no extra charge to the patient, to target that disc, and Tom wasn't any better. And so this is a patient that I said, hey, we're not getting any better. Let's refer you to the surgeon. This is before I met Dr. Swiatek, so I couldn't send him to him. This was an interesting patient because she came to me. She's in healthcare. She had the anterior cervical dissection fusion. She was fairly asymptomatic, was uncertain whether to pursue treatment or not. And I did a consultation with her. I looked at her x-ray, I looked at her MRI, and I said, hey, if you're not having symptoms, why do anything, right? And she said, well, I guess you're right. And so I want my referral relationships to know that I'm not just going to treat everybody because they walk in my door. This patient, I came in, I said, hey, you're asymptomatic. Let's not do anything, right? Let's leave well enough alone. And so she left me this Google review, and I gained a lot of her respect. One of the reasons that Dr. Swiatek and I want to put these together is because referrals are so important, right? Referrals help not only the patient, but it also helps to build our business. May 30th, 2024, I had this patient, Carmen. She came to see me regarding some issues that she was having. And I looked at her MRI and I said, I don't think I can help. And she said, but I don't want to have surgery. And I said, Carmen, would you rather me lie to you, take your money, treat you, and not get any better? Or if you are my mother, say, hey, I don't think I can help you, you should go see the surgeon. Really tough conversation I had with her. And she said, I think I'll act as your mother and not, go to the surgeon. I said, that's exactly what I would do if you were my mom. So not every patient is a good candidate for this type of treatment that we do. Our current approach to bulging, herniated, and degenerative disc, which is the niche that I'm in, is exercise, right? How many times do we tell our patients, go exercise, go move, don't sit on the couch? So we send our patients to yoga, go send them to a trainer, go work out, go lift weights. Hey, maybe you should take some supplements. Let's get some massages, go to a chiropractor. But a lot of times the patients that come to see me, they've already done all those things and it has not worked. So non-surgical spinal decompression is an intervention that can help people avoid drugs, not get injections, and eventually not have a surgery. But there's a 10% chance that I can't help people, which is where my relationship with Dr. Swiatek really works. So direct contraindications, I let all of the people that I refer to know that if anybody has a surgery, if anybody's a post-surgical patient, I'll call the surgeon directly and say, hey, this is what I want to do with the patient. Do you have any issues at all? And I think that's a respect component. And no surgeon has said no. But if they have a discectomy less than 90 days old, I won't touch them. If they have a fusion less than 6 months old, I won't touch them. There's some of my colleagues that will do decompression therapy with a spinal cord stimulator. I don't think the juice is worth the squeeze. So if that was my mom, I'd say no. Sorry, we can do other things, but spinal cord stimulator, I'm not going to do decompression on. Disc infection, of course, we're not going to treat. Cancerous tumors, neoplasms, we're not going to treat. So the cool thing is that there's some direct contraindications to decompression therapy, but the decompression works for women. It's a joke. Feel free to laugh. Thank you. Hey, Jack, can you edit that out and make sure you pipe in some laughs? So the DRX 9000, it works for women. Works for men. Crazy. Works for really tall men. Greg was 6'8", and he came to my office, and we got him better through treatment. So here I am standing on a chair. Works for not so tall women, which is interesting, right? Works for Spanish speakers. At one point in time, 50% of my clinic were all Spanish speakers because they don't have great access to healthcare because there's a language barrier. And a lot of these patients don't know where to turn. So I really found a niche in taking care of Spanish speakers. This guy drives from Logansport one way to come for treatment. He's been under treatment for about a year and a half now. DRX works for executives, works for blue collar workers. Ken is a really amazing story. I'd love to go in more detail about him, but he was a huge skeptic. He drives over 1 hour to my office, and his wife and I didn't know what else to do. His back pain was really bad. Used a walker most of the time. My wife said if it was her having the problem, then we would do the treatment no matter what the cost. So I recommended a minimally effective dose of treatment of 25 treatments. Ken left me this Google review, 5-star, I might add. 10 sessions in, and he started noticing a huge difference. Now at 25 treatments, he's not only thankful, but would recommend treatment for his back pain. And Dr. Lee really cares about his patients. So Ken was a really, really amazing patient. You can imagine how his biomechanics and his gait is off because he's got a prosthetic leg and he walks with a cane. And I was really, really worried about Ken when he started. And having a servant heart taking care of patients, I decided in my heart that I was going to help Ken no matter what, however many treatments. If it was going to take 100 treatments, I was going to treat Ken until we got better because he just really, really was on my heart. So a lot of patients ask about the patient journey in my office. Well, first I start with a consultation. Can I even help you? Because there's some patients that come to me, I can't help. And I'm going to tell them up front if I can't help them. If they have an MRI, which is really, really helpful, I'll review the MRI with them. I'll do a physical examination, and if it's indicated, I'll take their x-rays. Once I take their x-rays, I do what's called a report of findings. So I'll sit down with the patient and I'll say, this is what you got going on, this is what we can do, and this is what our expectations are after treatment. We do a minimally effective dose of treatment, however many. Bulging, herniated, and degenerative discs, they take time. All processes of healing take time. I found in my practice doing over 8,000 treatments that bulging, herniated, and degenerative discs, the sweet spot for treatment is about 20 to 30 treatments. My goal is within about 90 days, try to get that patient to the 50% mark and then reevaluate before we decide what we do next. And that's where we take the post-treatment x-rays. I'll review their progress with them. Like I did with Tony, hey, you have a 90% reduction of symptoms, disc height improved, great. I think you're a great candidate for maintenance. Or I have some patients, they're 100% better, great. Let's call me whenever you need me. I think we're okay on time. I wanted to talk a little bit about if decompression and traction are the same. They're not. The traction tables, like what a lot of us are familiar with, they're not cleared by the FDA. They don't have an FDA 510K code, meaning that they're not proven to be safe and effective. With the DRX was cleared in 2002, which is great, and that lets us know that the DRX has been proven time and time again with studies done by chiropractors, medical doctors, DOs, radiologists, that the DRX is safe and effective. Traction, as we talked about, has a 0-degree pull. If you have a lordosis in the lumbar or the cervical spine, if you pull on a 0-degree pull, you really can't target the angle. This is where traction is not effective with people that have any type of fusion in their lumbar or cervical spine. With the DRX 9000, we can change the pivot or the angle of the pull to target a specific disc and help imbibe that disc and heal it over the long term. With traction, you have a long, linear, sustained pull. You just pull and then it holds. It'd be like going to the gym and doing one rep and saying, I'm done for the day. When we go to the gym and we exercise, we do multiple reps to put more blood in the muscle. With decompression, we decompress that patient time and time and time again within one treatment session. And it does that via the logarithmic curve, which makes it more effective over the long haul compared to traction. I have some more slides on class 4 laser therapy. We can certainly talk about this. That's in my relief healing framework. I really wanted to talk about non-surgical spinal decompression and how we can specifically target bulging, herniated, and degenerative discs. So the whole idea is that physical therapy and injections and medications and all these things are great leading up to a point. But as I've talked about with Dr. Swiatek on multiple occasions, 90% of patients that he sees in the clinic, they're not surgical patients. And he says, I don't know what to do with these patients. That's how he found out about me. So this is a great intervention to do before we go and have to have a surgery done. So that's the end of my presentation. If everybody wants to get out their phone and write down my cell phone, so again, I can just directly text. I know that Jose, I probably call you like once a week of, hey, I got a patient in this part of town, where should I send them? So I would love to build my referral network. So my personal cell phone number is 574-322-7872. So if you would text me your name and the clinic that you're with and where you're at, so I can build that in my referral network and obviously send patients back and forth too, because I send a lot of patients out for physical therapy, massage, dry needling, because it's just not something that I do in my office. Cool. And if anybody has questions, we can certainly talk after, but I think they're ready to bring out I think we got Wagyu and a tomahawk steak coming. So if anybody has any questions, we can certainly talk after. Cool? Great. Excellent.